He's John Timpane.
And he's Don Rooney.
And this is
The Musical Innertube.
Now, you may ask, why is this podcast called The Musical Innertube?
And we may reply, because that's its name, of course.
Now, how did this podcast get that name?
Back in college, we hosted a radio show. Once, we tried to introduce a soothing musical interlude.
Instead, we messed up and wound up introducing a soothing musical innertube, and the name stuck.
So here we are, hundreds of years later, still talking
to interesting people about their interesting lives.
Difference makers who really make a difference.
We are very glad at the Musical Innertube to welcome back Art Caplan, the Drs. William F. and Virginia Connolly Mitty Professor and founding head of the Division of Medical Ethics at the NYU Grossman School of Medicine in New York City. And what that means is that he's a medical ethicist. He knows a lot about the state of play, about vaccines, about public health, about a lot of things that people are talking about on the street, and we welcome you back, Art. How are you?
Very good. Thank you for having me.
You bet.
Art, we've come to the official end of the COVID emergency as declared by the federal government. This is a thing that the president did, although the Congress was itching for him to do it anyway. So now that we have officially ended the COVID emergency, where do we stand, and what lessons have we learned, good and bad, from our long national nightmare?
Well, remember, deaths from COVID still occur. We declared it over, but I believe COVID in the U.S. is still the third leading cause of death right now as we speak. So it may be over for many, but it's still taking lives. And it's still causing one of my secretaries is out today, caught COVID for the fourth time. Doesn't feel well. She's sick. She has, she's not going to die, but she's certainly glad that she's been vaccinated. But nonetheless, she's sick and losing time from work. And there are many people around the world in countries where vaccines never showed up who are still getting sick from COVID. I think total deaths worldwide from COVID bordered on 7 million, and we had 1 million here. So do I think COVID should be over? No, I don't actually agree with that from the WHO standpoint. I would have probably not declared it ended. It's still too big a killer, too much disability. And we even have this sort of unexamined issue of long COVID. And what's that all about? And, are we devoting enough money and resources to examining people who got COVID and then seem to still be sick? That said, we're doing better. There's no doubt about that. Fewer people are dying. Fewer people get sick. So I understand partly why they made that case, but I think it's a little quick to take attention away from COVID right now.
Well, I want to say that of the three of us in this conversation, one has post-COVID syndrome. And it's long-term, and it's a real thing. I have to say, I have a headache all the time, every day. And it's been 3 months now, and it hasn't gotten any better. And, we're just sort of shrugging, my doctor and me, because it doesn't get in the way of my functioning, right?
Yep.
But there's that. My taste has changed a little bit. It's odd to find that oatmeal tastes like paint. It's just very strange stuff. And so that's a real thing. And I'm sure that for some people who have it much worse than I do, that can mean, missed days of work, right? It can cost the economy. I'm sure it's costing the economy millions and millions of dollars. Just this, just not feeling very well sometimes,
Oh, yeah. Yeah. My daughter-in-law was kind of susceptible in the first place. She had lupus. Then she got COVID. And now she's into long COVID. And it's just a situation where she's tired all the time, constantly tired. And she's missing days of work, and I had to check in and see if she's gotten any better at coping with it. But that was the idea, I guess, that she and my son started to get into, is how to cope with it, how to time out how long she would have strength and when to rest and all that sort of thing. So yeah, it's a very long-term problem for a lot of people. And like you said, Art, I don't think anybody is looking into it as a real honest disease and something that we need to treat.
Well, I'll jump in there and say one thing. There is a National Academy of Sciences and Medicine working group. I've given them some input, so I know they're there trying to just define long COVID. We don't even have an agreement. What are these symptoms? Headaches, fogginess, taste shift, tired. That describes my day every day anyway, and I'm not claiming to have long COVID. So, but you know what I mean? We don't have an agreement. So if you were to ask me how many people have it, I can't answer that because nobody agrees on what it is.
Right.
And if we had a magic bullet, a drug or something to give you that would kill off at least the symptoms, we might be getting protests that they've declared COVID over, with people saying, we've got to get this treatment out, but we don't have anything. So I'm sure John's visits to the doctor are getting frustrating because everybody sort of stares at each other and says, gee, maybe I could give you something for a headache, but I don't know if it's going to really help that kind of a headache, or,
Right.
If you're tired, well, what are we going to do about that? And I know nobody knows quite what to do about the taste issue, which may seem trivial to many people, but isn't. For example, if you're older, your appetite tends to fade anyway because your taste tends to fade. If you add to that COVID, then you don't eat, and then you get sick. And it can be very debilitating to, it's one thing to have to give up oatmeal, but if your taste shifts across the board and you just don't like eating anymore, that's dangerous for a lot of people. It's like when people don't pay attention to dental care and just say, well, that's kind of a luxury. You have oral health problems and you can't eat or chew or whatever, you are in big trouble. So things are not minor; they're serious. Anyway, so I do hope that we get some agreement, but both of you will be interested. Defining COVID will be hardly medical; it's always political too.
Oh yes, of course.
Right. So people are going to say, well, I want a broad definition. I want everything. If I had COVID, then anything that happened since then must be long COVID. And I want that so I could get disability benefits or more generous time off from work, or my spouse will be more tolerant of my behavior or whatever it is. And others are going to say, oh, well, we don't want to spend so much money on that, so let's narrowly define it. If you don't have 8 out of 9 symptoms, you don't have it. So listeners may be thinking, how does the ethics get into long COVID? It comes in right this way. You're going to define it broadly, generously, or you're going to define it narrowly. And that has nothing to do with doctors. It has to do with public policy.
Yeah. I'm sure insurance companies will have a lot to say about
exactly.
about how that is defined.
Exactly.
So what does it mean, Art, that our government has declared the pandemic over? Surely the CDC is keeping watch at least on the statistics, which you started off with, but they're not doing certain other things. Can you tell us, is anybody watching now, or is everybody going off and playing in the playground?
I think everybody went to the playground more or less. So all these political candidates are announcing DeSantis, or I guess as he now says it, DeSantis, Haley,
Nikki Haley,
South Carolina, Scott, but I don't hear any of them mention COVID. It's gone far, far away. Biden hasn't uttered the word COVID in a month. So CDC has a unit that will try to keep tabs on what's going on, but they're basically now not listening to reports. They're monitoring wastewater. They're looking for virus like that's out there in a group kind of way. Is there an outbreak in Philly? Is there an outbreak in Ridgefield, Connecticut? And trying to sample that way. And that's fine, but obviously it's not vigorous. You're going to get there later. The outbreak will have started by the time you pick something out of monitoring water supplies.
Yes.
So I'm going to tell you, when the declaration came out, everybody said, great. done with that. Move along.
The thing I'm wondering about now, too, is way before COVID, the emergency was officially declared over. People were going everywhere without masks. They were back into the swing of things.
Yep.
Schools were open. Businesses were open. It was like business as usual. You still occasionally see somebody with a mask. And actually, that's kind of the outlier now. You used to see a lot of people with masks. And now to see somebody with a mask is the oddity. So I guess we've just, no matter what the government said, most of us have already gone post-COVID and said, okay, well, that's a thing of the past. We're done with that. We're back to normal.
Yeah. And I think, again, vaccines helped, even though there was a lot of resistance. The majority of people did get vaccinated. I think, and I hope we're going to have a discussion about getting another booster in the fall as we begin to go back indoors. And I would hope that, again, many of us will get another round of COVID vaccine at that time as a booster. But you're right, masking, long gone. And I think also testing, long gone. Nobody's routinely testing when they get a cold or something. It used to be you ran right out and got a kit and were testing yourself. Now it's like, it's probably just a cold. And you also don't see, I'm going to say, as much compliance with COVID vaccination as I would hope in places like nursing homes. That's where, if we had 1 million deaths, I'd say 300,000 occurred among nursing home residents. They were super vulnerable. Sadly, hygiene isn't always so great. A lot of the workforce goes from one nursing home to another, the cleaners, the people who do specialty things, and they were carrying COVID. And I don't think the vaccination rates are great for the residents in nursing homes anymore, and I don't think they're great for the workforce in nursing homes. And by the way, prisons would count here too. Institutionalized disability, people who are in institutions with disabilities. So I think we let our guard down for those vulnerable groups way, 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 way too much.
Well, let's talk about the recently announced COVID booster and what your thoughts are about should we get it and when should we get it? For example, I'll ask for my own need because I could get it right now. I could go down to my local CVS or something and I could get stuck, which is fine. I've always kept up. Should I do it now? Should I wait a couple of months until I'm closer to the time I'm going to go to Italy? I'm going to go to Italy in October. So I'm trying to figure out when I should get this. What do you think, Art?
Well, I think 3 things should guide your decision. If you had a booster within the past year, you're probably okay to go through the summer. Not that its potency is as good as it was maybe even 6 months ago, but it's not nothing, and it sort of fades out. So did you have one recently? That's part of within the year, that's part of your decision. If you did, I'm not worried about that. I would say wait till the fall. If you are in a vulnerable group like these nursing home residents, I keep vaccinating them every 6 months, just on the idea that they're so likely to get infections and the flu, by the way, that you got to watch that very carefully. So am I in a extremely high risk population becomes a consideration. And then the third is, am I outdoors or am I still on Zoom? Who am I coming in contact with? If I'm running around, eating out every night, and then I go to every concert that there is, and I'm over 65, well, I'm maybe coming in contact with a lot of folks who might infect me. If I'm just still at home Zooming and I just see my family and friends and they're not particularly running around and we're having picnics in the backyard, with the open air, again, I'm saying the fall. So for me, most people could wait and really think about it in the fall.
Now, one of the other things that comes up with the official end of the emergency is that the government used to pay for the boosters. Now, does insurance pay for it? Also, the government used to pay for tests, and that's gone. You used to get like 9 free tests if you were on Medicare or whatever. And now you have to pay for the tests, which the tests, as I recall, were about $10 a piece. So it's not a huge amount of money, but still, How do we determine what gets paid for and what doesn't?
Oh, you're going to love my answer to this. Part of the budget reconciliation that they're fighting about in Congress, because the money on the table to return on spending is COVID money, right?
Yes, right. Unspent COVID money.
Yeah. So unspent by foot, it's supposed to be spent on what we're now talking about. But if you haven't spent it yet and you're looking for cuts, I'm going to say that's Biden's easiest move, is to say, oh, well, there was unspent COVID money. So believe it or not, the debt ceiling is driving, spending money on COVID.
So am I hearing you say that the government will no longer back us up on this and that we're going to have to ask our insurers?
I will bet that's the case. If I'm Biden and I need to give something back, I'm giving back COVID. I mean, not that I think it's wise, but if I got to look around and say, well, should I cut Medicare or should I give back unspent COVID money? I think I know where the politics take me.
Man,
it's fun.
We'll return to our podcast in just a moment, but first, here's a soothing musical interlude.
Art Caplan is the Doctors William F. and Virginia Connolly Mitty Professor and founding head of the Division of Medical Ethics at the NYU Grossman School of Medicine in New York City. Before that, Art was the Caplan Professor of Bioethics at the University of Pennsylvania Perelman School of Medicine in Philadelphia, where he created the Center for Bioethics and the Department of Medical Ethics.
Art is the author of 35 books and 800 papers in peer-reviewed journals. His books include Vaccination Ethics and Policy, The Ethics of Sport, Replacement Parts, The Ethics of Procuring and Replacing Organs in Humans, and The Case of Terry Schiavo, Ethics at the End of Life.
To learn more, see his page on the NYU Medical Faculty website at med.nyu.edu/faculty/Arthur-L-Caplan. And now, back to the musical Innertube, already in progress.
Because we are talking about COVID, and in many ways we're saying that, the virus never sleeps, even though right now it seems as though we're in not a pandemic, but an endemic. And Paul Offit was on our show saying that an endemic is when the greater population decides that it's livable and they go back to living. And that's actually a very nice pragmatic definition of the distinction, is when we decide we want to go back, we go back, and no more pandemic. And this is what you've been saying, isn't it, Art? Yeah.
Same thing. I absolutely agree. It's like, well, tired of wearing masks. I'm going to go to concerts. I'm tired of living this way. The death rates are lower. Okay, it's over.
So let me ask you about the situation in China, which I'm sure you've been hearing about, is that there are reports that in several Chinese cities, there is a high rate of infection in the Arcturus variant of COVID. And I'm imagining that these millions of folks aren't just going to stay where they're at, because right now China is not doing that anymore. Right. And these folks are going to travel, some of them. Even if a couple hundred travel, you could still get great. But we're talking about millions of people who are probably right now walking around, infected to some extent.
Right.
They
don't have to travel here. They might travel, let's say, to the Asian Games.
Right.
People from other places that are going to travel here. And that's initially how COVID actually spread. I'm not talking about did it start in a lab thing, but really got going. Actually, you said you were going to Italy. Remember they had those big soccer matches?
Mm-hmm.
Were a lot of people there. Then they traveled to France, and some tourists from here went there, and some of them came here. And that was really the ignition of big time COVID.
Yeah.
So that's definitely how things roll. And I'm worried about it. I think this looks like a new strain that's more infectious. I think that I worry about it too, because even if it isn't more lethal, if it's just easier to catch, if it's a new strain, then some of our immunity that we have from vaccines or catching it already won't work. And so we're going to be through another round of this stuff. And again, those who are particularly vulnerable, older, other diseases, lupus, immune disorders, cancer treatments, if your immune system is knocked out because you're on PrEP for HIV, we could see a lot more deaths spring up. And I'll go further. I don't know what Paul Offit said, although he should be listened to. He's a real expert on these things. But my view would be, if a new, more contagious strain shows up, we're in big trouble, because we're not going to find a lot of people willing to remask. There's a significant number of people unwilling to vaccinate at this point, including, by the way, a couple of Supreme Court justices who keep prattling on about civil liberties being intruded on by COVID measures. They just did that when they tried to overturn Title 42 in the immigration debate.
Yes.
It said, well, we can never intrude on our civil liberties. And it's sort of like, never? Even temporarily? Really? You want to go that far?
Well, how jolly. That's great. Boy.
So go to Italy immediately.
I hope it's still there at this rate.
That was my next question. Lessons learned. I hear over and over again from experts, especially, on the news, who are talking about the end of the emergency, that we're not prepared for the next big wave of viruses or whatever that's going to hit us, that we're going to slam the same way we were when we were slammed with COVID.
100%. Learn nothing. All we did was get pushback against public health. So we have a lot of people who say, I'm not trusting any vaccines that pharmaceutical companies make ever again. Okay, well, they're our best weapon against all infectious diseases: measles, mumps, polio, flu, everything, diphtheria. Now we have a significant hostile element. We even have a guy running for president, RFK Jr., on the I Hate Vaccine platform. That's not the world's best prep for whatever might show up, whatever nasty bug. We don't like masks. Masks are for weenies. Masks are for people who have no courage. This isn't a great stance. I don't have to worry about my neighbor. Screw my neighbor. I do what I want. I'm not morally responsible for anybody else, says, including, I'm going to say it again, the Supreme Court. And intrude on my civil liberties. Can't have workplace restrictions or any sort of a shutdown, even if we all agree that maybe we don't want schools shut down for a year. But how about if we had an outbreak in Cleveland and we wanted to shut down the schools there for 10 days to get ahead? I don't know. I'm not sure we could even get that. So, no, I think we came out damaged. We came out divided, the country, and we came out almost with a more selfish attitude. And that's not what you need when you're battling pandemics. You need solidarity, community, you need altruism. We didn't get a lot of that.
There's a friend of mine who says it is the football syndrome, that when you're a football player and you break your leg on the gridiron and you're brought back in, the first impulse is to tape it up and run back out for the next series of plays because you'll be called a wuss if you don't. And that's kind of what a lot of people did when they were looking at masking or going back to school or going back into businesses, that people who were afraid of the virus spreading or not quite sure that we were over this were kind of looked upon as wusses. Is that kind of what we're looking at?
Yeah, some of that became, instead of praising the prudent for wearing a mask, if not to protect themselves and to protect others, they became weenies and softies. Being smart and trying to help your neighbor does not turn you into a wuss. It turns you into, I think, a morally commendable person. And we didn't even get the ethics message out properly throughout this pandemic. It was like, where are the church leaders? Why aren't they out there saying, protect your neighbor, look out for the vulnerable? I actually heard some people say, well, the people who are dying, a lot of them are old and many of them are fat.
Right.
Okay.
Right. Yeah.
I don't, what's with that?
Call the herd.
Exactly. Darwinism, social Darwinism.
So what can we do to turn it around for the next, and be prepared for the next big pandemic?
we're going to go through a lot of deaths and people are going to get tired of it, and then we'll turn around. Nothing else. It's going to take a real catastrophe for people to say we got to stop this and we can't keep dying. And the deaths have to reach beyond the elderly and institutionalized people.
Mm-hmm.
We had a huge outbreak that was killing children, we would pivot quickly. I'm sure about that.
Mm.
And if it was killing young people, some flu version that attacked people in their 20s, we'd pivot. A disease that takes a big toll in the over 65s, I'm afraid, I don't agree with this. I argued against it. I think it's immoral, but there is a tendency to sort of say, well, they were going anyway.
So basically, we got to buckle up and get ready for more of the same.
Yeah, I do. I sadly believe that. I'm not happy about it, but I do. And it's not to say we shouldn't keep bemoaning it and complaining like we're doing here and trying to not only shift the public health department, but shift the moral conversation so that we hear more in spiritual settings, religious settings, theological settings, and bioethical settings about what it means to be a good person. And I'm all for that, but that's slow change. That's slow. It's not like you show up at the Kiwanis Club and give that talk and everybody runs out and donates to poor people.
Well, Art Caplan, thank you so much. Before we go, I think we should end on a really happy note. Something that you mentioned just before we got started recording this episode of the Musical Innertube, I'd like to go back to, which is the notion of a coming vaccine that I think a lot of people will be interested in getting. This is a vaccine against melanoma. Can you explain where that is, what it is, and its prospects for coming to light?
Really good news, because melanoma is a big killer around the world. I think it's number one, by the way, cause of death in Australia, I believe.
Yeah, of course.
It's up in the top 10 here. People not only get sun exposure going fishing or to the beach, but a lot of us kind of sadly go to tanning parlors and get overexposed there. And so melanoma, dermatologists make their living off preventing melanoma. I know this because my wife is in that risk group. I think John is in that risk group. So
sure am.
There are a lot of people who have this challenge. We didn't really have much to do about it. And if you didn't get regular screening, a lot of people die because we didn't have any intervention. The mRNA vaccines, they're the ones that control how our DNA makes chemicals that get into our cells and become us. And this RNA was used for the COVID vaccines, and it made a lot of people nervous about RNA vaccines. Well, guess what? The same platform, RNA vaccines, are coming to prevent melanoma. They're really close. They're only about a year out. FDA absolutely will approve them. One of the lead researchers is here with me at NYU. I know what the data looks like. It looks really good. It looks so good that if somebody offered it to me tomorrow morning, I would take it pre-FDA approval. I mean, it's good. The results are good. And I think we're going to be able to make melanoma partly a thing of the past. You still want to get screened if you're in a high-risk group, but I really think this is going to cut the death rates significantly. It may come as a shock. State of Idaho, in its frenzy to get rid of COVID vaccines, said no one should be giving mRNA vaccines in the state. That's going to be a little disappointing if you're at melanoma risk, because those are mRNA vaccines.
Yeah, we're going to have melanoma tourists who go to other states.
Yeah, and then people will flee the state of Idaho to cross the state border to get vaccinated. We'll have an underground vaccine railway.
Well, that is happy making, because I've wondered about that. And like many people, I've known folks who've lost their battles with melanoma. How long do you think this will be in the hopper before it becomes available? The
standard answer, and you guys know this from interviewing lots of people, is 5 to 10 years will produce the cure for something. I'm going to say a year.
That is breathtaking.
Yeah.
Well, thanks again, Art. Now I'm happy where I was sad before.
Go out and lie in the sun immediately.
Science gives and science takes away.
Thank you, gentlemen.
And thank you for listening to the Musical Innertube.
Our lovely little podcast is available everywhere good podcasts are found. Listen on your favorite platform, and if you like what you hear, please give us a good rating.
And spread the word. Tell your friends about the Innertube and let them know they can subscribe to the podcast on our website, musicalinnertube.com.
There you can listen to all of our podcasts, see pictures and biographies of our guests, and contact us. You can even click on the microphone button in the lower right corner to leave us a voicemail.
And don't forget to leave your email address on our Talk to the Tube page so we can stay in touch.
And you can email us directly at musicalinnertube@gmail.com.
And as always, thanks to virtual band Car Radio Dog for our theme music.